Hello everybody and welcome to our module on rhabdomyolysis. Rhabdomyolysis is a syndrome caused by muscle necrosis, and it's a life-threatening condition because it can lead to renal failure and death. In rhabdomyolysis, there is some trigger that leads to muscle damage, and the contents of the muscle spill out into the body, and that's what leads to the clinical syndrome of rhabdomyolysis. There are many things that can cause rhabdomyolysis, but on this slide I've listed some of the important ones. The first one is intense physical exercise, especially if dehydrated. So a person who goes and exercises for hours in the hot sun without drinking water, their muscles can be deprived of blood flow, and that can lead to rhabdomyolysis. Crush injuries from trauma, where muscle tissue is crushed beneath an object like a car or a boulder, these things can lead to rhabdomyolysis, obviously because there's direct damage to the muscle tissue. And then there are a number of drugs which have been associated with rhabdomyolysis. The classic drug class that causes rhabdomyolysis is statins. Statins are generally safe, but a tiny minority of patients will develop rhabdo, especially if they take a statin together with another drug that can cause muscle damage. Some fibrates can cause rhabdomyolysis, and then colchicine is also a classic cause because colchicine is directly toxic to muscle tissue. So if you understand what the contents are of muscle, then it's very easy to understand the clinical findings in rhabdomyolysis. So muscle cells contain creatine kinase, and elevated levels of creatine kinase are the hallmark of rhabdomyolysis. Patients with rhabdomyolysis always have high CK levels. In addition, there are a bunch of other enzymes that can spill out into the blood from muscle, enzymes like aldolase, lactate dehydrogenase, AST, and ALT, and the levels of all these things can be elevated in the serum of patients who have rhabdomyolysis. Muscle cells contain lots of potassium and lots of phosphate, and therefore hyperkalemia and hyperphosphatemia are classic findings in rhabdomyolysis. And hyperkalemia, as you may know, is potentially life-threatening. I talk about hyperkalemia in a separate video. Muscle cells also contain lots of purines. Purines are bases like adenine and guanine, and they are components of nucleic acid found in DNA. And they are metabolized to uric acid by the liver, and so for this reason, patients with rhabdomyolysis often have hyperuricemia. Muscle cells also contain lots of myoglobin. Myoglobin is a protein monomer. It's different from hemoglobin, which is a tetramer of 4 proteins linked together. Myoglobin is a monomer, but similar to hemoglobin, it contains heme. This is heme here at the bottom right side of the screen. It's an iron molecule surrounded by a porphyrin ring. And the purpose of myoglobin in muscle cells is to bind oxygen for use by muscle tissue when you're exercising. So when myoglobin spills into the plasma in patients with rhabdomyolysis, it travels to the kidneys where it causes renal toxicity. Myoglobin has a couple of negative effects on the kidneys. First of all, it can obstruct the tubules, and it's toxic to proximal tubular cells. It also causes vasoconstriction, especially in the medulla, which is the inner portion of the kidney, and this leads to renal hypoxia. So all of these things are going to cause renal failure. So the classic labs in a patient with rhabdomyolysis are increased BUN and creatinine in a pattern consistent with intrinsic renal damage, and I talk about this in the video on acute renal failure. And then also because the kidneys are failing, there will be hyperkalemia. So in rhabdomyolysis, the kidneys really take a hit because not only is myoglobin renal toxic, but there's volume depletion that occurs in rhabdomyolysis because intravascular fluid leaks into muscle tissue as the muscle is dying. So not only are the kidneys exposed to toxicity from myoglobin, but also there is less blood flow to the kidneys because fluid is leaking out into necrotic muscle tissue. And therefore the feared outcome of rhabdomyolysis is renal failure and death. And the way people die from rhabdomyolysis is death due to renal failure. Let's talk about the clinical features of rhabdomyolysis. The symptoms are muscle pain, muscle weakness, and dark urine from myoglobin in the urine. This is an example on the screen here of what the urine can look like in a patient who has rhabdomyolysis. The diagnosis can be made by measurement of the creatine kinase. This will be very high. A normal level is under 250. In rhabdomyolysis, it's usually over 1,000. Sometimes it's as high as 25,000 or more. When patients present with rhabdomyolysis, because the urine is discolored, the urine is often sent for urinalysis. And if you insert a dipstick, like what's shown on the screen here, into a sample of urine from a patient with rhabdomyolysis, it will indicate the presence of heme. This can make you think that the patient must have hematuria, but remember, the presence of heme could indicate blood in the urine, but it can also indicate myoglobin in the urine, which is what happens in rhabdomyolysis. When you examine the urine under the microscope, you will see no red blood cells in rhabdomyolysis. This is a picture of what red cells look like under the microscope. You won't see this in a patient with rhabdomyolysis because they don't have blood in their urine. What's making the urine dark and what's making the dipstick positive for heme is myoglobin. So putting this all together, the classic findings in the urine of a patient with rhabdomyolysis are dark urine, a positive dipstick for heme, but no evidence of red cells on microscopy. Make sure you understand this because in board questions describing patients with rhabdomyolysis, students often mistake it for a case of hematuria. The mainstay of treatment for rhabdomyolysis is volume resuscitation. Remember what I said before, volume can be lost into necrotic muscle tissue, and that can make the renal failure worse, and renal failure is how patients die from rhabdomyolysis. So IV fluids are always administered. Usually it's isotonic saline, which is the best volume expander of the IV fluids. And you titrate the infusion rate of the IV fluids to maintain a good urine output. If the patient is making good levels of urine, that means they're volume resuscitated. If they're making very little urine, then you need to give them more IV fluids. In addition to volume resuscitation, electrolyte abnormalities need to be treated, and then finally, dialysis is required for some patients with rhabdomyolysis if they have hyperkalemia and severe acute renal failure. When you volume resuscitate a patient with rhabdomyolysis, you have to be careful that the patient does not develop a compartment syndrome. A compartment syndrome occurs when there's increased pressure in a closed anatomic space, like in the skin of the leg or the arm, and it can be seen in severe rhabdomyolysis. It's usually after fluid resuscitation because the fluid you give to the patient ends up spilling into an extremity, which can cause compartment syndrome. This is a picture of a man with compartment syndrome of the hand here. The clinical findings are worsening edema of the limb and the muscle tissue. The limb is usually painful, and then the skin surrounding the limb will be tense. And compartment syndrome is a medical emergency. It can cut off blood flow to the extremity. This can lead to ischemia and necrosis and loss of the limb. I'll finish by mentioning hypocalcemia. When patients initially develop rhabdomyolysis, calcium will accumulate in the damaged myocytes. What this means is in the early phases of rhabdomyolysis, many patients have mild hypocalcemia. However, as the patient begins to recover, the calcium that is trapped in the damaged myocytes will be released and the levels will return to normal, and they can even sometimes become elevated. So for this reason, you don't ever want to treat mild asymptomatic hypocalcemia in a patient who has rhabdomyolysis, and this often comes up on your boards. If initially the patient presents with a mildly reduced calcium level, don't treat that with calcium supplementation because then when the patient enters the recovery phase, they will develop hypercalcemia. And that concludes our video on rhabdomyolysis.